With that, we would like to now begin with our last segment of the PSR review course. For this, we would like to invite the chairpersons, Dr. Hafiz Mahmood Riaz, consultant rheumatologist at Aga Khan University Hospital, Karachi, and Dr. Zafarullah, consultant rheumatologist at Shifa International Hospital, Islamabad, as the chairs of the session, along with Dr. Ziauddin from Lady Reading Hospital, Peshawar, as co-chair. We request our esteemed chairs to kindly join us on stage.
We are now pleased to welcome Dr. Raza Jaffery, consultant rheumatologist from Fort Worth, Texas, USA. Dr. Jaffery is an experienced clinician whose work reflects a deep commitment to advancing patient care and promoting global collaboration in rheumatology. His presentation, titled Sarcoidosis, the Master of Disguise in Rheumatology, explores one of the most fascinating and diagnostically challenging conditions in the field. Ladies and gentlemen, please join me in extending a warm welcome to Dr. Raza Jaffery.
Thank you so much for giving me this opportunity. I'm glad to be back in Lahore. There have been a lot of changes in this area since I last visited Lahore. घरों में तो मर्दों पे बीबियाँ हमेशा से मुसल्लत थी. आपके यहाँ ये मामला अब सूबाई सतह तक जा पहुँचा है. अलबत्ता खुशाइंद बात यह है कि घर में तो शौहरों पे मुसल्लत हैं बीवियाँ, लेकिन विफाक में तो हुकूमत मियाँ की है. So I will now request you to just relax, sit back, wear your seat belts, and be ready for a rough session. This is going to be a relatively interactive session. So if you really want to get rid of me in next 20 minutes, please try to answer the questions in a timely fashion. As you can see, this slide is pretty empty. Any help from our resourceful pharmaceutical industry to fill up this slide is going to be highly appreciated. You must have all realized what is the primary objective of any speaker in a scientific session. Our secondary objective is that we will be talking about the differential diagnosis, clinical features of sarcoidosis, and management of sarcoidosis. So which one of this chest X-ray is abnormal? Is this abnormal or this abnormal? This is abnormal, that's correct. So what is the abnormality? Excellent. And the next question will be, what is the differential diagnosis? Just of this X-ray. Can anyone speak a bit loudly? Great. Sarcoidosis, infections, malignancy. TB in infection, that's correct. So looks like you know all the answers to my questions. I'm preaching the believers, but I will still keep preaching you. So basically, this is the differential diagnosis over here. Sarcoidosis, infections like tuberculosis, fungal infections, lymphoma, metastatic malignancies, viral infections. So one way to differentiate the causes over here is infectious versus non-infectious. So infections include tuberculosis, fungal infections, while in non-infectious causes, sarcoidosis, as well as malignancy, pneumoconiosis, and certain autoimmune diseases. How can you differentiate between the two? Generally, the infections will be associated with constitutional features like fever, night sweats, weight loss. There will be lab evidence of infections like leukocytosis, increased ESR, C-reactive protein. And there could be microbiological and serological evidence of an infection. On the other hand, in sarcoidosis, actually sarcoidosis is one of the most common cause of asymptomatic bilateral hilar adenopathy in a young adult. It can be associated with clinical features. Features like necrotizing granuloma, caseation, or central necrosis will be going in favor of infection, while non-necrotizing lymphadenopathy or non-caseating granuloma will go in favor of sarcoidosis. In tuberculosis, necrosis, and neutrophilic infiltrate in lymph node aspirates are highly suggestive of TB infection. Fungal infections may show calcified nodes or mediastinal granulomas, and fungal etiologies should be considered in immunocompromised patients with appropriate epidemiologic exposure. Few words about tuberculosis versus sarcoidosis. Clinical presentation: chronic cough, fever, night sweats, weight loss, hemoptysis will go in favor of tuberculosis, while, as we said, it could be asymptomatic or there could be dry cough, dyspnea, fatigue, skin changes like erythema nodosum. And systemic symptoms are generally more prominent in diseases like tuberculosis and less prominent in diseases like sarcoidosis. Radiological changes can be helpful. In tuberculosis, it may be unilateral or asymmetrical. On the other hand, generally in sarcoidosis, it's bilateral and symmetrical. Extrapulmonary involvement can be seen in both the diseases. On bronchoalveolar lavage, CD4 to CD8 ratio has been reported as less than 3.5 in tuberculosis, while it is generally more than 3.5 in sarcoidosis. Histopathology can be helpful in differentiating between the two diseases, and acid-fast bacilli can be associated with tuberculosis. Differentiation between lymphoma and sarcoidosis. Lymphoma may be associated with B symptoms: fever, night sweats, weight loss, rapidly progressive lymphadenopathy, often asymmetrical, may involve extranodal sites like CNS, GI tract, bone marrow. We have already talked about the clinical features of sarcoidosis. Lymph nodes, as I said, may be asymmetric in lymphoma, often cervical, supraclavicular, and generalized lymphadenopathy are features of lymphoma. In sarcoidosis, it's bilateral hilar adenopathy. They may be bulky in lymphoma, and they are generally not bulky in sarcoidosis. Lab features like cytopenia, elevated LDH, abnormal flow cytometry will go in favor of lymphoma, while elevated ACE level, although it is not specific for sarcoidosis, but elevated ACE levels, hypercalcemia, lymphopenia can go in favor of sarcoidosis. PET scan often is focal in cases of lymphoma, and it has been described as diffuse in cases of sarcoidosis. On CT scan, large discrete nodes may be necrotic in lymphoma, while they are smaller, non-necrotic in cases of sarcoidosis. And histopathology can be helpful in differentiating between the two diseases. Few words about hypersensitivity pneumonitis versus sarcoidosis. Two clinical presentations have been described for hypersensitivity pneumonitis. One is acute, one is chronic. Acute is flu-like symptoms, cough, dyspnea, symptoms occurring hours after exposure to the antigen. And chronic is associated with weight loss and progressive dyspnea. We have talked about clinical features of sarcoidosis. And then certain features will go in favor of sarcoidosis versus hypersensitivity pneumonitis, like centrilobular ground glass nodules, upper mid-lobe fibrosis, while in cases of sarcoidosis, it's mainly upper lobe involvement. Pathology can be helpful. Generally, with hypersensitivity pneumonitis, you will see poorly formed non-caseating granuloma. Non-caseating granuloma are seen in sarcoidosis also, but they are well formed. And then lab features like increased natural killer T cells are seen with hypersensitivity pneumonitis as compared to sarcoidosis. Diagnostic clue: history of antigen exposure, positive precipitating antibodies, improvement with avoidance to antigen will go in favor of pneumonitis. In sarcoidosis, multi-system involvement or asymptomatic elevated ACE levels, specific syndromes that we will discuss later, are associated with sarcoidosis. Which of the following is considered pathognomic for sarcoidosis? Any? So the correct answer over here is lupus pernio. Lupus pernio is highly specific for sarcoidosis, and along with Presentations like Lofgren syndrome and Herford syndrome may allow diagnosis without any additional testing. Just a few words. Herford syndrome is defined as parotid gland enlargement, uveitis, and facial nerve palsy. Lofgren syndrome is hilar adenopathy, erythema nodosum, and arthritis. This condition is generally seen on the face, cheeks, and nose, and is highly specific and suggestive of sarcoidosis. As I said earlier, sarcoidosis is a multi-system disorder. It is not only confined to the skin or joints. It can involve skin, like what we have discussed. Erythema nodosum can be seen. We know about the pulmonary involvement. It could present as cardiac sarcoidosis, neurosarcoidosis, so it's a multi-system disorder. Musculoskeletal manifestations are seen in about 1/3 of the population with sarcoidosis. A wide range of symptoms, starting from mild arthralgia to widespread destructive bone lesions. And inflammatory tendon lesions and periarticular swelling is more common than actual synovitis. Arthropathy in sarcoidosis has been described as acute or chronic. Acute is more common than chronic. It frequently involves the ankles. It is self-limiting oligoarthritis. In chronic sarcoid arthropathy, which is less common, it is polyarticular and may involve upper extremity joint. Musculoskeletal involvement can include periarticular swelling, tenosynovitis, and less frequently destructive bone lesions. American Thoracic Society highlights that periarticular arthritis, especially in the right context, is quite specific for the diagnosis of sarcoidosis. Again, there are certain features which are associated with good prognosis versus poor prognosis, like onset of the disease at the age of less than 40 has good prognosis. Late onset, black race, female gender, lower socioeconomic status is associated with poor prognosis. Similarly, advanced lung disease, scalding stage 3 or 4 is associated with poor prognosis as compared to stage 1 and stage 2. Extrapulmonary involvement like lupus pernio, cardiac sarcoidosis, neurosarcoidosis, hepatosplenomegaly is associated with poor prognosis, while Lofgren syndrome is associated with good prognosis. And there are also genetic associations. Some of them are associated with good and some of them are associated with worse prognosis. This can be used as a diagnostic algorithm for the diagnosis of sarcoidosis. So the patients can be divided into 3 groups. If the features are highly suggestive of sarcoidosis, like Lofgren syndrome, Herford syndrome, or asymptomatic bilateral adenopathy, you can make the diagnosis. You do not really need to have any additional testing. If the patients do not have features suggestive of sarcoidosis, that is easy. Patients who have some features of sarcoidosis really need additional workup. That could be bronchoalveolar lavage and biopsy. And then based on that, they can be divided into 2 groups. If there is evidence of granulomatous inflammation, make sure that you are excluding other causes of granulomatous inflammation before making the diagnosis of sarcoidosis. So according to the American Thoracic Society, which is the first line treatment for symptomatic sarcoidosis. Can you speak a bit loudly? C, that is correct. Corticosteroids are still the first line therapy, although the things may change based on recent clinical data, but still, corticosteroid stays the mainstay of the treatment. What are the principles of management? Most patients do not require therapy because the disease may resolve spontaneously. So if the patients have no symptoms of mild symptoms, they may not require any systemic therapy. And treatment is required if patient has significant symptoms, there is threatened organ dysfunction, or there is risk of irreversible damage. Unfortunately, there is not of high quality clinical data looking at the management of sarcoidosis. Most published data about the use of immunosuppressive agents is anecdotal. Clinical trials are based on limited number of patients. Most trials in sarcoidosis management have focused on pulmonary and systemic sarcoidosis, and there is very limited data about the management of sarcoid arthropathy. This trial was recently published in New England Journal of Medicine, and interestingly, In this, they are comparing methotrexate with corticosteroids. So in the past, corticosteroids were used in both arms. But over here, in this trial, they used methotrexate versus prednisone, and the primary endpoint was changes in the forced vital capacity. And interestingly, the treatment with methotrexate was non-inferior to that of prednisone at 24 weeks. Again, as you could see, both of the study arms achieved similar results. Prednisone was able to achieve it earlier as compared to methotrexate, probably because of the late onset of action. I understand this is a very busy slide, but basically it is telling you that if the patient is asymptomatic, they do not need any treatment, they can be just observed, or they may need limited treatment like topical steroid or steroid inhaler. If the patient is symptomatic or has organ involvement, then you start with the first line, second line, and third line therapy, and we are going to talk about it. This is another study in which methotrexate now was used as a steroid sparing agent. Most of the clinical trials have used immunosuppressive therapy as a second line drug. So in this trial, they used methotrexate plus steroid versus steroid plus placebo. After 12 months, methotrexate group required smaller amounts of corticosteroid as compared to the control group. There was no significant difference between methotrexate and control group in terms of lung function, radiographs, symptoms, or toxicity. So the conclusion was that methotrexate can be used as a steroid-sparing agent in acute sarcoidosis. So the therapy can be divided into three groups. First line therapy is still corticosteroids remain the mainstay of the treatment. Typical dose is 20 to 40 milligram. The dose can be tapered over 6 to 18 months based on clinical, radiological, and functional improvement. For limited sarcoidosis, you can try to use topical steroid and steroid inhalers. Second line therapy basically is a steroid sparing therapy. It is needed for the patients who are either refractory to glucocorticoids or are requiring long-term steroid therapy. Methotrexate has been widely used. Other agents include azathioprine, leflunomide, and mycophenolate. Hydroxychloroquine is particularly useful for cutaneous disease, hypercalcemia, and some neurologic manifestations. Anti-TNF antagonists are being used for refractory or severe disease, especially with life-threatening organ involvement. Anti-fibrotic agents, although not have been approved yet for the treatment of sarcoidosis, are being used off-label for fibrosing disease secondary to sarcoidosis. And there are several other agents like JAK inhibitors, IL-6 inhibitors, statins, which are under investigation for the management of sarcoidosis. Thank you so much for the teamwork.
Thank you, Dr. Jaffery, for sharing your valuable insights. Also, before we move on, all participants are kindly requested to maintain the conference decorum. Up next, we have Dr. Haseeb Ahmed Khan, Clinical Director and Consultant Rheumatologist at University Hospitals Dorset, United Kingdom. Dr. Khan is an accomplished clinician and leader known for his dedication to improving rheumatology services and advancing clinical standards in patient care. His talk, intriguingly titled Nightmares in Rheumatology, takes us through one of the most complex and challenging cases encountered in clinical practice. Please join me in welcoming Dr. Haseeb Ahmed Khan to the stage.
Thank you very much. Bismillah ar-Rahman ar-Rahim. In the name of Allah, the most gracious, the most merciful. My name is Haseeb Ahmed Khan. As I have been introduced, I would first like to congratulate the organizing committee for arranging and executing this well-organized conference. My special thanks to my mentors, Professor Nigat Mir Ahmed, Dr. Sumaira Faman, Dr. Ahmed Saeed, for giving this opportunity to present some cases. I am conscious that we have very limited time, and I have gathered 3 cases to present. I have made the presentations very precise and only added information which is very rheumatological so that we can stick to the point. What I would want is that we make these case presentations more interactive, and I want you to participate and give me your thoughts of what you think is happening with the patients. So let's start with the first case. This is a young female who is 23 years of age, presented in 2017 with abdominal cramps, pain, blood in the stools, and erythema nodosum-like lesions on the legs. She was diagnosed with Crohn's disease that was based on histopathological confirmation on colonoscopic biopsy. She was initially started on azathioprine and prednisolone, and she was doing really well for like 2 years, but then her symptoms started to worse. She was having repeated flares, and she was switched to injection adalimumab with some good response, and clinically she felt that her symptoms are quite well controlled. Around December 23, she presented with disseminated varicella zoster virus infection, which was treated with antivirals. But she felt that since then her health has been going downhill. She's feeling fatigued, lethargic, and she also has some sore throat and multiple coryzal infections. She presents to us in the A&E in February 24 with shortness of breath, cough, and she was off her adalimumab due to recurrent infections. Her examination shows that she was quite breathless, required oxygen support at 3 to 4 liters per minute. She was tachycardic, hypotensive, and was admitted in the ITU. She was having some murmur over the heart and some bruise. The baseline investigations showed anemia, raised CRP, normal creatinine. Her immunological screen was negative. As she was off the medication, we still ran the adalimumab levels, which came back as positive without any antibodies. Her HLA-B51 screening was negative, only a borderline positive IgM anticardiolipin antibodies. This was the trend of her CRP, and if you see that since the varicella zoster virus infection, she has been having some raised CRP, and even before, when she was switched to adalimumab, there was some raised CRP which is going on. So we ordered a CAT scan basically to rule out certain causes, and I would just want to know what you think that this is happening over the both lungs. Any idea? Any thoughts? Whatever. So consolidations are there on both the lungs, this one and this one. But the interesting part was that the CT scan also highlighted some other things. I would really want to know if anybody would tell me anything which is seen in the CT scan. Any idea? Sorry? Vascular, yes. So what is exactly happening? Narrowing. So if you see that there is total obliteration of the right renal artery on certain, if you go for the left renal, there is initial narrowing and then post-stenotic dilatation. And you can see it over there as well. If you see the last slide where the arrow is, there is narrowing of the aorta, and after that there is some distension. This is a 3D image that we picked out, and again this shows that there is left renal post-stenotic dilatation, and you can see that the right renal is completely obliterated. So here we are with this patient who also has some cardiac involvement. We did a PET scan which shows increased enhancements over the myocardium, but just to let you know that initially patient was quite sick and she was in the ITU, and this PET was carried when she was stabilized. So the pulmonary involvement was basically resolved or decreased, and there was cardiac enhancement. So what do you think is happening with the patient, and what is the differential or possible diagnosis? Sorry? Vasculitis. Which one?
Polyarteritis nodosa.
So we also thought on the same lines, and we ran a lot of screening. We did the viral screen. Everything came back negative. Negative profiles for the ENA, immunological profiles, cryoglobulins, everything that we could order. And the echocardiograph showed a very reduced ejection fraction. And what do you think would be the cardiac cause of her symptoms? Sorry? Coronary involvement. Yeah. But she didn't have very high drops, or even the pro-BNP was slightly elevated. So we also thought of a similar diagnosis, and we made the diagnosis of Takayasu's, but we ruled out Behçet's by doing an ophthalmologic screen. We checked the histopathology again for Crohn's disease to see whether there is some vasculitis, and there was no features of that, and it was typical for Crohn's. And we made the diagnosis of Takayasu's coexistent with inflammatory bowel disease. And how will you treat this patient? So she's in ITU, she's very sick, hypotensive. How are you going to treat the patient? Steroids or just steroids? Okay, so we had a lot of discussions among nephrologists, hematologists, because she had a positive IgM cardiolipin. We also thought of catastrophic APLs, and we started her on anticoagulation, but the final diagnosis was Takayasu's, and we started her on methylpred and cyclophosphamide infusions, followed by infliximab and methotrexate. You can see that since starting of treatment in February 24 until now, the CRPs have gone really well. She's off steroids, she's doing really well, having a regular follow-up, and her cardiac functions improved. I haven't shown, but we also did a cardiac MRI, which suggestive of Takotsubo cardiomyopathy, and after follow-ups in 3 months, her EF has returned back to normal. So now the diagnosis is coexistent Takayasu's with Crohn's disease and Takotsubo cardiomyopathy. So we did some literature research, but I am just conscious of time, so I'll just highlight what we suggested. So Crohn's disease is associated with Takayasu's, and majority of the patients have Crohn's disease preceding the inflammation. Anti-TNF remains the drug of choice. Ustekinumab and JAK inhibitors are showing promise, and ulcerative colitis is being treated by upadacitinib, so that is still something which can have a dual effect. But tocilizumab, which is very good for Takayasu's, is something which might not be well tolerated in patients with bowel disease. So just to be careful of that. So let's go on to the case number 2. An 83-year-old female, history of recurrent pulmonary embolism, having been investigated twice with thrombophilia screen, APL's profile. Nothing came up, and is on lifelong anticoagulation. CKD secondary to hypertension, diagnosis 2014 with a GFR of around 30, stable, nothing of untoward, and again having a DVT. In 2023, she presents with what she says is that there are blisters over the lower legs which burst and release fluid, and then she develops stiffness of her thighs, forearms, and arms with joint movement restriction. There is no history of Raynaud's, dysphagia, or other connective tissue disease symptom. She had an MRI of her right knee in 2022. So examination was showing thickening and hardening of the skin, and there was sparing of fingers and toes, no features of scleroderma, pulses, and neurological examination was intact. Anybody who would like to comment on this image? Okay. Sorry? Yeah, I got the first part, so it's will be all in the page. Okay, that's good. Very good. And we ordered some investigations. Obviously, we wanted to rule out other causes, which came back as negative, extended scleroderma antibody panel, Lyme serologies, ruling out any underlying malignancies, which all came back negative. But let's see if this blood test changes some diagnosis. So before she presented to us, she was having some eosinophilia around 3,300, which was in 2023, but by the time she came to us, it had normalized. So there was a spike in eosinophil, probably relating to a symptom. So does that change a diagnosis? Eosinophilic fasciitis. And how will you diagnose this condition? And, sorry, biopsy and eosinophil count. Any other modality which can help in the diagnosis? Which would really help? So the differential diagnosis on top of our list was eosinophilic fasciitis and nephrogenic systemic fibrosis, considering that she had an MRI with low GFR, scleroderma, and mimicus. So she had an MRI scan which showed this sort of a picture. And would anybody comment on the scan? So there is thickening of the deep fascia, you can see it, and if it would have been, this is the T1 image, it would have been hyper intense if it was a flare of fat suppressed. So this is basically thickening of the deep fascia, and this is a biopsy report. This is, I've taken from up to date, this is of the patient. This one is the normal slide, and this one is showing excessive collagen deposition. So this likely is eosinophilic fasciitis, and we treated her with oral prednisolone and methotrexate. But after that, she presented to us with this in 2 months. So now what do you think has happened with the patient? So 2 months methotrexate, she presents in A&E and has this CT scan. MTX-induced pneumonitis, a very likely possibility, and that is what we thought. We also ran some screening as well, so she came back to be positive CMV, as well as her beta-D glucans was very high. So we stopped her methotrexate, started her on antibiotics, increased the steroids, and started her on valganciclovir as well as antifungals. So she was recovered well, and her CT scan image improved. We later started her on mycophenolate and abatacept, and this has really improved his condition, and now she's able to walk. So this is the literature review on eosinophilic fasciitis. Just to mention some of the features, steroids remains the mainstay of treatment. Biologics, IVIG, can be shown promising results in refractory cases, and another IL-5 inhibitors such as mepolizumab or benralizumab might show some future response. So case 3, this is the last case, and I'm just short of time. So erythema nodosum, seronegative arthritis, diagnosed in 67-year-old male in 2015, started on steroids, methotrexate, intolerant to hydroxychloroquine, switched to etanercept but not fully controlled, and added on as a secondary failure, switched to adalimumab. Now this patient has seronegative arthritis, and bearing in mind that his all previous investigations for other causes and seropositivity were negative, even so sarcoid, and he was not able to reduce his steroids despite being on biologics and methotrexate. So in 2019, he presents with these lesions. So anybody who tells me what this can be? Neutrophilic dermatosis. So it's sweet syndrome, in other words. And yes, he was having this, and he was treated with, he was diagnosed on a biopsy, and he was treated with Dapsone and then Lugol's iodine for relapse cases. But any differential that comes into mind with these two manifestations in a single patient? We checked for sarcoid, and biopsy was not suggestive. He wasn't having the typical hyalurolymphadenopathies. We had a workup for PET scan as well, so no suspicion of malignancy at this stage in 2019. Okay, let's move on further. In 2023 and 24, he developed these features suggestive of MDS. He developed progressive cytopenias and was found to have blast cells on his bone marrow biopsy. Now, can anybody give me a differential unifying diagnosis in this patient? Vexus. So this is very typical for Vexus syndrome, and that he wasn't able to taper steroids. We had him sent to the excellence center, and under the hematologist, his biologics were stopped, and he was started on azacitidine. Even after 6 cycles, he wasn't able to improve, and a stem cell transplant was planned, but unfortunately, patient passed away. So this is the vacuolization, which is very typical in Vexus syndrome, and this is the dysplasia, which was seen in his bone marrow biopsy. So the diagnosis remains Vexus, the treatment remains with steroids and immunomodulatory therapy. When it comes to the hematological involvement, of course, you need to consult the hematologist and start him on hematological treatments. This is a teaching point, but just now, in August 25, this is the first paper that has been published by the ACR, which highlights all the essentials for Vexus, and I would really want you to read through it. Thank you.
Thank you, Dr. Haseeb, for such an engaging talk. We now have the privilege of hearing from Dr. Binit Vaidya, consultant rheumatologist at the National Center for Rheumatic Diseases, Kathmandu, Nepal. Dr. Vaidya is a respected clinician who has been actively involved in advancing rheumatology practice and professional collaboration in the region. His presentation for today is titled Treat to Target in Gout. How low should we go? Please join me in welcoming Dr. Binit Vaidya to the stage.
Thank you for the kind introduction. At the onset, I'd like to thank the organizers for considering this topic and this with this esteemed audience. The scientific sessions well planned and so mesmerizing, as I actually completely forgot that I also have to deliver a talk, and I was completely engrossed in the other lectures. So the task assigned to me is like treat to target in gout. Sounds quite simple, right? But the second part of the question is quite complicated. How long should we go? That's the trick, I think, because everybody is talking about lowering uric acid, but how low should we go? So before we talk on treat to target, let's define the target, because we assume that uric acid is the only target in gout. Even the patients understand my uric acid is low, but I'm getting pain. Uric acid is high. We ran only following uric acid blindly. So for any disease, to monitor an outcome of a disease, there are outcome measures defined. And these outcome measures are defined by OMER Act and defined as a tool or instrument that is used to measure the effectiveness of an intervention. It might be a quantitative measure like blood pressure, a semi-quantitative like health assessment questionnaire. It might be a qualitative patient satisfaction scores. It might be generalized or disease specific. It might be single parameter like we say uric acid, or it might be a complex scoring system like DAS28, SLEDAI, or Selena, where they are disease specific and there are multiple parameters combined. And to define this outcome score, OMER Act have given stringent filters. So we cannot say that because uric acid is associated with gout, you monitor uric acid and gout is controlled. The anti-CCP is associated with rheumatoid, but we do not monitor it, right? So similarly, it has to, any outcome measure has to fulfill the criteria for truth, discrimination, and feasibility, and those are identified by a rigorous set of statistical tests. OMER Act was founded in 1992 in Netherlands, and it started working on outcome measures on gout in 2002. And in 2000, this publication is from 2014 for outcome measures on the studies of acute gout. As you can see, they've defined the core domain in acute gout as pain, patient global assessment, activity limitations, joint swelling, and tenderness. No uric acid, right? In acute gout, so the value of uric acid does not matter. And these are the core domains, and the tools to measure these core domains are again defined. See, most of them are Likert score, and activity limitation for that they use health assessment questionnaire, but none for specific for gout has yet been validated. For chronic gout, the core domains are acute attack, tophus burden, quality of life, activity limitation, patient assessment, and here there is the tophus count and urate levels. So when you are talking about a long-standing disease and chronic gout, there's the significance of the urate level as compared to the core domains for the acute gout. So how do we measure these core domains? Serum urate by biochemical lab testing. Gout flares, how to measure gout flares, none is still endorsed by the OMER Act group. Tophus burden, they used vernier calipers for the sentinel tophus, but the ultrasound measurement of tophus burden is now rapidly coming up, and most probably in next update, instead of vernier calipers, the ultrasound tophi measurement would come up. And there are other scores like short form 36 health assessment questionnaire and VAS score. So this is actually a comprehensive target that defines a remission in a gout cases. And in addition to these measures, they have also studied the radiological markers. The three measures are X-ray, ultrasound, and MRI. And as you can see, ultrasound fulfills all the three criteria to measure gout. including inflammation and joint damage as well as the urate deposition. So you can see urate deposition as seen on as double contour sign and the aggregates or tophi. You can see synovial inflammation as power Doppler optic, and you can also see erosions in an ultrasound. Other imaging modalities do not comprehensively measure all the three parameters, and they have further gone into describing these measures, which is, I think, the out of scope of this talk. So for the biochemical parameter, OMERACT has finally agreed that serum uric acid is a reliable surrogate marker, not a direct marker but a surrogate marker, because there is a strong independent association between the endpoint, the clinical endpoint, and the target endpoint. The evidence suggests that the interclass effect as well as intraclass effect of lowering uric acid by different drugs, be it xanthine oxidase inhibitors or use pegloticase, if the uric acid remains in target for a longer period of time, the most of the cases are in remission. So yes, till now, uric acid is the surrogate marker that is taken as a treat to target measure. So this is the remission criteria, where serum uric acid is one of the criteria. There should be no tophus, there should be no flares in 1 year, there should be no pain, patient global assessment less than 2, and that these parameters should be measured at least twice in 12 months interval, equally distance, means every 6 months. So to define as a patient in gout being in remission, like at a point of time, we can just say that the patient is gout free, flare free, and the patient has uric acid level at target. But we cannot say the patient is in remission until we have monitored the patient for 1 year. So the target now comes again down to uric acid, and there are multiple organizations in their consensus statement guidelines. They have defined the target uric acid levels. ACR, EULAR, and APLAR consistently agrees on maintaining serum uric acid to less than 6 in normal cases, and in chronic tophaceous cases, it's advised to maintain the uric acid level to less than 5. BSR is more, British Society is more stringent in maintaining uric acid level in less than 5, even in normal gout cases, non-tophaceous cases. Who disagrees is the American College of Physicians. So American College of Physicians guidelines, it was published in 2017. The classical guidelines, which we used to say, start urate lowering therapy only after 3, if the frequency of attacks is more than 3 times a year. That was the advice. They do not give the guidelines for the target of uric acid that has to be achieved, the frequency of monitoring of uric acid levels, and they say that, you can see the point number 2, they recommend against initiating long-term urate lowering therapy in patients after first attack or in patient with infrequent attack. Even with frequent attacks, they advise discussing benefit, harm, cost preferences, and the guidelines shows reluctancy in initiation of urate lowering therapy in cases of gout, and which was quite soon criticized by the GCAN, the Gout Hyperuricemia Crystal Associated Disease Group. This is led by Professor Lisa Stamp, and they are working relentlessly on defining the targets in the gout. And they've said that they argues that the pathophysiological basis, the current evidence, they agree that there is no head-to-head trial on treat to target versus treat to symptom in gout, but whatever the pathophysiological evidence and the observational studies and trials are available, they show consistent improvement with continued maintenance to the target level. So they criticize the ACP in the next publication in Nature. But then to solve this problem, 2 RCTs are on the way. Again, this is in the recruitment phase. The GO test has completed the recruitment phase. The other trial is still recruiting. They have even published abstract in EULAR last year, and they have shown that with treat to target strategy, patient achieving serum uric acid less than 6 was 77%, and the incidence ratio of gout flares was 54% higher in patients who were treated with symptoms only. Like they go to doctor only when the symptoms are there, and they are not prescribed the regular urate lowering therapy, not monitored frequently, and the target is not set. So we are in agreement that basically till now, though there are very outcome measures studied in gout, uric acid remains the valid surrogate target. Treat to target strategy is better than treat to symptoms, and is generally accepted by major rheumatology societies that the serum uric acid of less than 6 and in tophaceous gout of less than 5 is acceptable. So this brings us to the next part of the question: how low should we go? Now then, for this, I'll take you back to history. Why did uric acid first of all occur in us? Because it was due to non-functional mutation of the uricase gene that occurs around 18 million years ago, and again around 8 million years ago, that rendered the uricase enzyme non-functional, so that the uric acid could not metabolize to its soluble metabolite allantoin, and it gets accumulated in our body in higher mammals. Why was that important? Because uric acid level stimulates fructokinase, and it accelerates fructose metabolism, and it helps in generating ATP and storing energy. This now is the cause of fatty liver in patients with gout and hyperuricemia, but at that time it had a survival benefit. So in the medieval period, when there was famine and the people shifted to vegetarian diet and the diet based on fruits, when the animal food was not available in the medieval period, the increased uric acid, increased fructokinase activity, it was believed it gave the antioxidant property, it increased intelligence, neural reflexes were enhanced, and in this way it was a boon. But with the advent of sugar and then a lot of farming, high glucose overload in our diet, the same boon then gradually turned into curse, increasing the symptoms of metabolic syndrome. So uric acid basically was a friend to us. It had high antioxidant activity, but the antioxidant activity was limited extracellularly. So 55% of the extracellular antioxidant activity is mediated by uric acid. But once the concentrations are high and the uric acid concentration increases intracellularly, then the reverse occurs. There is increased reactive oxygen species and nitric oxide, endothelial dysfunction, and there are a lot of inflammatory mediators, NLRP3 stimulation, and that is causing this intracellular accumulation, is causing more of the pathophysiological features. So the extracellular uric acid was basically protective. Then this paper was published in 2022, where it showed a U-shaped curve on all-cause mortality with correlated with serum uric acid level. So this data was not on gout patients treated with urate lowering agents. This was basically from people who are having genetic defect that causes hypouricemia, familial renal hyperuricemia, and other causes, and they have seen that lower uric acid level in this 200 micromole per liter, which translates to 3.3 milligram per deciliter, again raises the all-cause mortality. And in these groups, they have seen that many multiple studies have shown that with uric acid level less than 3.5, less than 2, there's increased risk of mainly Alzheimer's disease, Parkinson-like features, acute renal injury, nephrolithiasis. So there are multiple harming effects of lower uric acid that has been identified in people with genetic causes of hypouricemia. Does that translate to our patient with gout? There was a study that was published again in 2022, where there were two groups with intensive lowering of uric acid level to 3.3 versus treat to target normal approach, where the mean urate level achieved was 5. What they saw was the intensive target was difficult to achieve. So even with intensive treatment, only 62% achieved low uric acid level. The mean allopurinol doses were higher when they tried to achieve a lower uric acid level, but the ultimate disease activity score, bone erosion, and the outcome measures were not statistically significant. So the study did not show those adverse outcomes that we discussed in this population, but what it definitely showed was lowering uric acid below 3.3, below 5, did not add any extra benefit to the patients with gout than treating the patients with a level of 5 to 6. So the answer is to stay between 3.4 to 6. Less than 3.3, they have shown harm and no added benefit in disease outcomes. More than 6, it defies the definition of treat to target. So the actual target, the lower limit should be 3.4 to 6 milligram per deciliter. So serum uric acid is a current valid surrogate marker. Treat to target is definitely now accepted as being better strategy than treat to symptoms, though we are awaiting the final results of the 2 trials. Uric acid was an evolutionary boon that turned into curse. It has a survival benefit, and lowering it significantly does not benefit our patients also. There are many more studies going on uric acid and hyperuricemia. We are working on the incidence of fatty liver disease, the risk of liver fibrosis. We already know about nephrolithiasis, microalbuminuria, and cardiovascular morbidities. But all of the management guidelines, if you read the guidelines, it is mentioned in the very first overarching principles that the metabolic parameters in gout should be assessed and should be managed according to the regional guidelines. But in specific gout patient, when should we monitor, how often should we monitor, these details are yet to come. In APLAR, we are working on a gout registry, and definitely by the end of 2026, all these parameters would be included in the new gout management guidelines. Finally, I'd like to invite you to the Nepalese International Conference that's going to be held on March 2021. The dates are covered because it's shifted due to the current political instability. I hope to see you, everyone, in Nepal soon. Thank you very much.
First of all, I would like to thank you to all these speakers by delivering their talks on time, and to the audience as well by staying engaged during the first half of today's conference. And we now have some time for a few questions, and we have received 2 questions. I would encourage the attendees, if they have any further questions, the speakers would be happy to answer. I have got a question from Dr. Muhammad Ali. This question is for Dr. Haseeb Khan. Dr. Haseeb Khan, are there any clinical predictors or biomarkers that suggest which cause patients will progress to develop MDS?
Sorry, I can I ask you to clarify the question. Predictors for MDS formation in vexus?
Yes, and any clinical predictors or biomarkers that can actually indicate that some specific patients may develop MDS over time.
So generally what happens is that in patients with vexus syndrome, they are usually old age males between 50 to 70 years of age, and they run through different phases. It's very difficult to actually pick up on an initial phase, which might be an inflammatory response. But when they are going, macrocytosis is something which is quite prevalent. So if you are consistently seeing raised inflammatory markers, inflammatory features, macrocytosis, there would be a chance that the cell lineage would be dropping if it is a vexus syndrome, and a full-fledged MDS picture might evolve. So thinking of these lines, macrocytosis is something to look for in a patient with given inflammatory dermatological involvement, and maybe it would start with single lineage effective and going into a more MDS pattern.
Thank you.
I hope this answers.
I think you have another question. There is another question for you.
Thank you, Dr. Haseeb Ahmed Khan. I have another question for you. It's from Dr. Salim. And the question is, a 35-year-old lady diagnosed Takayasu disease has developed bilateral renal artery stenosis in hypertension. Please guide about further management.
So basically, the important part of managing such patients is to identify the disease activity. You might be having patients which would have inflammation and now develop residual stenosis, and the patient might not be active. So the first thing is to identify inflammation. You might order an MRA to see for activity. You can see for inflammatory responses, maybe some info through a PET scan. Initially, the treatment remains with steroids and immunosuppression. Some patients might be waiting for a relapse to start the immunosuppressive treatment. Methotrexate, MMF remains the cornerstones, and then the biologics with anti-TNF and tocilizumab for isolated Takayasus would be considered one of the most advanced treatments. Just to highlight the reason why we gave cyclophosphamide. So cyclophosphamide is something which is kept for very aggressive disease with new life-threatening organ involvement and stenosis, like that in our patient it was happening. So we only reserve cyclophosphamide for like life-threatening conditions, but otherwise steroids, methotrexate / MMF would be fine to start off with.
Well, thank you, Dr. Haseeb. I have another question, and it's again from Dr. Salim, and
Yeah.
the question is for Dr. Binit. And the question is, when should hyperuricemia be treated? Like, it's a common dilemma. We see patient on acid-laureate drugs, and they have no symptoms at all.
Okay, so should I recite the guidelines or because that's an area of debate worldwide. You know, when should you treat hyperuricemia if the patient does not have acute attack of gout? So if the patient has acute attack of gout, the current guideline says you do not need to wait for frequent flares. If the patient has acute attack of gout, clinically, acute attack is diagnosed clinically. If you have crystal examination facility, you can do it. If you have ultrasound showing double contour sign, that's very specific for gout. And once you have documented gout, you usually start treatment with urate lowering agent. So in the current day scenario, based on ACR, BSR, and APLAR, except the ACP, American College of Physicians guideline, works to wait for at least 3 gout attacks in a year. You can start urate lowering therapy after a typical confirmed gout attack. For asymptomatic hyperuricemia, there is no convincing evidence that suggests lowering the uric acid level has survival benefit. But if the patient with hyperuricemia has other comorbidities like urate nephropathy, nephrolithiasis, and now we are studying on the increased liver fibrosis risk. We are seeing FIB-4 score, we are seeing insulin resistance. So if they have other metabolic risk factors, it is better to start on xanthine oxidase inhibitors. Because if you see the pathophysiology...
Thank you, Binit, for the interest of time, because we have a Juma prayer, so just after, in like 5 minutes, so we have to wrap up this session. I would request the chairpersons to kindly conclude.
Yeah. Thank you so much, all the speakers as well as the audience. Thank you, speakers, for very elaborative talks. And I think we will move on to the conclusion of this last session of the first half of the day. Thank you.
I would now like to invite the worthy chairs, Dr. Hafiz Mahmood Riaz and Dr. Ziauddin, along with Professor Ahmed Said, Professor Kamran Hamid, who is the past president of PSR, and Dr. Saira Elaine Khan, the co-convener of PSR 2025, to come on stage to present a token of appreciation to our speakers. The first speaker, Dr. Raza Jaffery. Our next speaker, Dr. Haseeb Ahmed Khan. And last but not least, Dr. Binit Vaidya. We would now like to present a token of appreciation from Professor Ahmed Saeed, Professor Kamran Hamid, and Dr. Saira Elaine Khan to the chairs of the session, Dr. Hafiz Mahmood Riaz, and lastly, Dr. Ziauddin.
Ladies and gentlemen, with this, we're going to conclude our session for today. We'll now be taking a break for lunch in the Grand Ballroom and the Jummah prayers in the Pearl Continental Mosque. Please don't forget to fill out your forms so we can give you your CME credits. Please make sure to rejoin us promptly after the break at 2 p.m. for the short pediatrics rheumatology course for family physicians, pediatricians, and adult rheumatologists under APLAR patronage, which will be held in the Crystal Hall B, while simultaneously we will be having a basic MSK ultrasound workshop for the registered participants in Crystal Hall A. Thank you for your cooperation.